Oh no, that's Petrie.
Hello, John.
Hey, Ronaldo, how you doing?
I can see you. Please, I need to do panelist.
Yeah, well, you refused to come in twice. Twice I admitted you. Hold on, let me get it. Hold on.
Oh yes, sorry. All right. I can. All right.
Right. There you go. You're coming in now.
Thank you. ¿Cómo estás?
How you doing? How you been?
I'm very good here in my stay here in Tabasco, south of Mexico. That's right.
Oh,
I'm waiting for Dr. Ruiz and another professors. I had a question for you. I see you are working all the day, every day.
yeah, I love it.
You have
I
a
love
lot
it.
of energy.
I
You're a
like
genius.
this, like you like neurosurgery. I mean, it's
Yeah,
something that gets me up in the morning, keeps me excited, you know,
yeah.
just like neurosurgery is for you.
Yes. I work every day and to Monday on Saturday and every day I am working. Yesterday, I here in Mexico is a lot of violence. It's a little war, not war. Yesterday, I operate a patient with a ball in the head, and every day, it's the same problem here in Mexico.
Ronaldo, have you met Fitri? Fitri?
Yes.
She gives me such a hard time. You know, man.
Yeah,
Hey, Fitri,
Hello, John. How are
say hi to
you?
Ronaldo.
Hello, yeah,
hello, Fitri.
Leonardo.
How are
We
you,
are
Fitri?
chatting WhatsApp.
Tomorrow I send you the article. It's a very nice article for you
Thank
for your
you. Thank
for
you so
your. Yeah.
much.
This is a
Thank you
very
so
nice.
much.
I hope this topic is as well for your foundation. Thank you for the invitation.
Thank you so much.
Yeah,
Thank you.
you're a neurointensive nurse, or just a ICU nurse or a neurointensive, Fitri.
Basically, I'm a neuroanesthesiologist.
Oh, I'm sorry, neuroanesthesiologist.
All right.
But no, I'm lecturer to be a lecturer and then teach for the medical doctor. It's like in India, it's MBBS.
Well, you know,
It's like
if you want to do,
medical student.
Fitri, if you want to do a webcast for neuroanesthesiologists, that would be fine if you want to do one.
Yeah, but maybe for nowadays there is, in
Do
my
you want to, do
country,
you know how to do it? You know how to do that, right? Do
neuroscience
you know how
is,
to do Zoom, right?
huh?
You know how to give a PowerPoint presentation?
Yeah, tomorrow.
Yeah.
But in Indonesia, but tomorrow is like a congress, nationally congress in my country for
Oh, okay.
anesthesiologists. So
Nice.
tomorrow morning, I will talk about uh management strategy for opioid
Can you
free.
show us, please, the conference? Show us the conference.
But it's Indonesia. Is that okay?
Well,
Oh
yeah,
yeah, okay.
you put it up.
Maybe it's like
Show me the
a check.
conference. Show me the website.
Okay.
Show me the website. And don't argue.
Okay. Can you see?
Yeah.
Can you see?
Yep.
Oh wow. Very,
Is
very
that
nice.
okay?
Put a presentation
No.
on. Say,
Well,
what language
but
is
I
that?
cannot. I cannot see my presentation. Okay. But I cannot see my.
Yeah, you gotta
My
put it on
person,
presentation mode.
but maybe I can stop control site.
You've got to learn how to use that.
Yeah. Please teach me now. View share gallery and then teach her how to because I cannot see my slide too.
Okay, well, you need to learn the platform. You need to learn the
Yeah.
platform of Zoom.
Yo. Tomorrow I can see it, but
You have to learn
today.
it. You have to, I can't tell you,
Yes.
you have to learn it.
No. Please tell me how
Well, you have to,
to.
no. A neurosurgeon, if they're told to learn something, they learn it. I mean, there's no two
Show.
questions about, oh,
Hi,
somebody
view.
show me.
Show me
No, just
data.
learn it.
Huh?
Right, Ronaldo? No one
Yeah.
takes you by the hand, a neurosurgeon, and says, let me show you how to do a Zoom. No, they know they have to learn it, so they learn it.
Oh, yeah.
Yeah.
No one teaches
Yeah.
them, they learn it.
Yeah.
Just like a
It's pretty important
Slide control.
neuroanesthesiologist.
Maybe
yes,
They
it's
slide
very
learn
important
by
to share
control.
doing. They
all the
learn it.
information. It's very important.
Uploading
Okay,
meeting.
I'm gonna get you off the screen share there.
Yes, because yesterday I cannot when I'm presentation I can do how to share and then yes as a background yes I know what mana ya tadi ya ini share
Okay.
as a background. Okay, can you see it?
I can
Yeah.
see you only.
Huh? You can see me now. Can you see my slide?
I can see your desktop.
Stop there. Okay, I will send again. Or maybe I have to close it.
Dr.
Maybe.
Luis is coming.
Ahí está.
Lewis
Reinaldo,
is
sí,
here.
ahí está.
Yes. Can you see my background? Oh, kenapa ya jadi nggak bisa? Thank you, John. So I can check my slide for tomorrow.
Oh, it's a nice background. I like that background. Okay, Demetrius
No.
Lopez.
Wait. This is not this one. Share. Tunggu. Oke, ini ditutup dulu kayaknya. Tunggu. Aku tutup dulu semua. Oke.
Yeah.
Wait. Share.
Good afternoon, everybody.
Document.
Lewis, how you doing?
Good morning here in Mexico.
Hi, Beatrice, how are you?
I'm fine, thank you. But I cannot see my. Wait. I have to learn for it. Yesterday I can do it. Wait. Kenapa ya ini nggak bisa? Side by side. This is my slide. Share. How to?
Okay, Lewis, how you doing?
Okay, well. I
Okay.
just sleeping a little bit after lunch.
Oh, okay.
Typical from Spain, siesta.
Demetrius knows, right? He knows, right?
I think yes. I call him.
Yeah.
Just a minute.
Yeah, please.
Yeah. Oh, share.
In the meanwhile, I'm going to show you a picture of my background.
You can see my slide. Can you see my slide now?
No, please don't mess around. We're going to start soon, okay?
Oh, I see.
Oh, go ahead. Oh, yeah, we can see the slide, but you need to put it.
Can you see my slide?
Okay, you see
Yes,
at the bottom right, there's 4 icons at the bottom right. You see
Can
those
you see
icons?
my slide?
You have to click one of those. Click one of these icons here.
Demetrius, soy Luis.
Yeah.
Click one
Oye,
of those icons.
estamos conectados, te estamos esperando.
Share. Okay.
So
Can
click
you
on
see
those
my
Vale.
slide
icons
now?
at the
Que
bottom.
tú eres el primero. Conéctate, ¿ok?
Can you see my
Okay.
slide now?
Yeah,
¿Estás
yeah, that's
preparado?
it. That's
Ok,
it.
perfecto.
That's it.
No,
Gracias.
it's for
Perfecto.
tomorrow, but it's in Indonesian. I'm sorry.
Thank you
What's
thank you
wrong
for
with
the
Indonesia?
permission. Thank you for the
Yeah, because
permission. Thank
tomorrow
you.
is a national congress. Yeah.
That's good.
I'm
I will
That's
try
good.
to
You get a good
connect. I will try to
presentation.
connect you for your topic, right?
Okay, what language is that? That's not English, that's Philippine?
Se conecta ahora mismo Demetrius. Se están esperando.
Okay, okay.
Díselo a
Wait, I
Bene.
will learn again
Yo
for
mandé
tomorrow.
un link a él,
Vale,
a
pero
su
dile a Bene que
LinkedIn.
ya está Demetrius esperando para conectarse.
Vale, ya le digo, ya le digo.
Okay.
Luis, mandé un link, Dr. Lopez. Su
Yes.
LinkedIn.
Don't worry. I call with
Can you
Demetrius
see?
now.
Okay.
I contact with us
Louis,
in few minutes.
the last time I see him was in Spain
Yes, I know.
5 years ago. I saw him.
Yes.
Thank you so much, Luis, John, Ronaldo, for a support for me.
Of course, your friend
Hey, maybe
Luja is my support for me every time, every day. Okay.
Thank you.
yo voy a vivir en la finca de Luis.
No, I stay in Madrid. Today is in Madrid.
Oh, okay. Okay,
Professor
yo voy a
John.
quedar en su finca.
Cuando quieras.
Okay,
Con Fitri.
para 2-3 meses.
With Fitri.
No, yo puedo cuidar los
Professor John.
vacas.
Professor John. Professor Demetrius is waiting for you, your trains in the chat, please.
Oh, okay.
He's connected right now.
This is the background for tomorrow.
Thank you. I will try to connect. Thank you.
Okay, pero estamos esperando para Speaker Grande.
He's waiting for your permission for connecting as panelist.
¿Quién?
Dr. Demetrius.
Benitez?
Demetrius, the professor. He's waiting for you for your permission.
Oh, Martinez?
As a panelist. Demetrius Lopez.
Okay, yo entiendo, pero ¿cuál? Dígame el nombre.
Demetrius Lopez.
No hay Lopez en el panel. No hay.
Sí. He's the best speaker. Demetrius.
Oh, aquí está.
Okay. Magay.
Ándale, pues.
He's here.
¿Cómo están? ¿Todo bien?
Todo bem.
Hola,
Todo bem.
Demetrius.
Hey, how are you guys?
Obrigado.
Obrigado.
Demetrius, the last time I saw you was in Madrid.
I know it's been a while now.
Yeah, 5 years.
And Luis, how are you doing? Are you doing okay? Everybody healthy?
Everybody with your support.
Okay, good. So let me make sure I get a good image here. My hair doesn't look good. Hold on a second.
No, don't worry. Look back.
Yeah, Louis doesn't have to worry about that.
Okay, am I sharing the screen? Do you see it?
Go ahead. You're sharing the Zoom screen now.
Yeah.
But you do a lot of these now, right, Demetrius?
Yeah. Let me see here. Let me try again. Okay, you should see now. Okay, it's right on top.
Yeah, make presentation mode. Do you know how to do that? There you go. Perfect. You see that, Fitri? You see how we did it?
Time for any little presentation for Professor Demetrius Lopez?
Okay, wait a
Yes.
minute. Are you guys ready to start?
Start.
Okay,
right.
here we go. Here we go. Let me put it on. Oh, let me put it on. Okay, it's on YouTube. Okay. Okay, let's start. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. Live like a block away. We have the extreme honor of having Demetrius Lopez, a gentleman I haven't seen for 5 years. The last time I saw him was at a conference by Lewis. Lewis had a great conference, and we might start it again. He brings you on a tour of La Prada. Did you go on that tour, Demetrius?
No. Yes, the tour is fantastic. Yes.
And then he took you to Flamingo another night. I couldn't make that because I stopped drinking. But anyways, we have this presentation tonight, and I'll have Lewis introduce Demetrius. Hello, Lewis.
Yes, fantastic, John. Thank you very much. Thank you, Demetrius. Thank you, Reynaldo. Of course, thank you, Fitri. Fitri Sevipanti is at the heart of Juha Herrensniemi. Okay, is the girlfriend of Juha. Be careful, Demetrius, because now many people. I listen you, I listen me, I listen John and Reynaldo. Be careful with your talk, because sometimes you are right in your thing, but it's not all right with every people. Okay. Thank you, Demetrius. You're welcome here with me.
It's a pleasure to introduce Professor Demetrius. He's a well-known professor, international professor and friend in the global vascular therapy community. Okay, Professor Demetrius, the floor is yours. Thank you for connecting.
Well, thank you. Of course, Luis, Reynaldo, Fitri, and John. This is really a very amazing topic, and I do think it's going to be controversial. So that's going to be the fun part of it, because so Luis and Reynaldo, I know you're very familiar with what we do, which is we have extended our reach in neuro treatments from the conventional open surgery to endovascular therapies. And we've been doing this for a long time. But what I'm going to talk to you about now is about going transvascular. So you're going from the endovascular approach to the outside of the blood vessel. And that is incredible, because this is just the beginning of it. And this is the first disease that we're treating, but we are already talking about the drainage of subdural hematomas going through the middle meningeal artery into the subdural space and draining the hematoma without doing a craniotomy. So it's, I love neurosurgery. I am a neurosurgeon. I really enjoy doing the procedures, but I do think that there is something really exciting about this new life, the new approach where we are today. So I will kind of share with you now some of the background on this. The idea here is that the shunt surgery, which is the ventriculoperitoneal shunt, it is been around for about at least 60 years. So you can see that from the training of a neurosurgeon, this is probably one of the early surgeries that we learn and that we master. We become very good in doing the shunts. They are very common procedures we do all the time. The issue here is that even though it seems simple to do, there are a lot of things that they're mild sometimes they can be quite complications. It's a straightforward procedure, but you can see the pictures here that sometimes, even though the Coker's point, which is the place where we play on the frontal approach to the lateral ventricle, you sometimes can have a hematoma on the source, on the puncture site. There are a lot of issues also with placement of the catheter. Sometimes the catheter doesn't stay in the ventricle and you place a little bit off the ventricle. And sometimes you can have also the overdrainage with presence of subdurals. So these are some of the issues that we maybe take for granted, but it's a procedure that was the only solution we had in the past and has been helping us for a long time. So there are other technical issues too, so you have problems with when you have shunts that have a collapsed ventricle, very difficult to get access to them. So you may not be able to have a spot to drain, as well as problems in the abdomen, folks that have had previous surgeries or have infections in the abdomen that could be an issue for the absorption of the spinal fluid. Now, there are different types of hydrocephalus, obviously, but it is very, very much a dysfunction of the circulation of the spinal fluid. So you can have today, different types of communicating hydrocephalus, non-communicating hydrocephalus. The types that are non-communicating are usually because of an obstruction on the pathway of the spinal fluid. And also the bottom line, though, is that the fluid has to be produced at the level of the choroid plexus and then circulate to an area that we call the granulations of Pacchione. And these granulations will absorb the spinal fluid. And this happens throughout the superior sagittal sinus and also into the spinal canal. And actually, as a matter of fact, a very, very interesting pathology that we're treating nowadays, and this is new since we last talked, Luis, is the treatment of CSF venous fistulas, which are incredible. So patients that present with low pressure hydrocephalus, sometimes they have bilateral subdurals, they have enhancement of the dura. You then do a selective lateral position myelogram, first day in the right side, second day left side, and you can see the myelogram contrast going through the venous anatomy, filling the azygos system. Incredible, we can go now through the azygos system and place onyx and occlude the CSF venous fistula to fix a condition that is also involving, the circulation of the spinal fluid. But this is a topic for another day, and I just wanted to share with you that it's a very hot topic, this issue of what's happening with the spinal fluid. Is it just simple production, circulation, and drainage, or there's more to it? And it seems to be linked to a lot of diseases that we are treating nowadays. And in this case here, if you look at the number of people that have a condition, normal pressure hydrocephalus, which is it's about 700,000 folks that are suffering from this condition. So it is an interesting reason or reversible reason for decline of neurological function in the elderly age. So these patients, many times they will, the conventional hydrocephalus is not applying for normal pressure hydrocephalus. This is usually elderly population, and they will have the signs of gait instability, urinary incontinence, and cognitive decline. But here, imagine that if you start thinking about in general, a condition that is very common like hydrocephalus. So the treatment that we have today, when you look at, this is a series by McAllister reviewing a long series of complications. They came up to 40% of complications in the first year of treatment of hydrocephalus, and more than 50% at 2 years. And this is really, for me, an awakening. I think we take for granted for sure, and all kinds of complications, but it could be from infection, failures, or clogging up of the catheter, or it could be issues with over drainage or having to redo the procedure. So incredible how there is a problem here. Now, the issue, this is United Kingdom Shunt Registry showing that the revisions, they tend to plateau after a period of time, but there is definitely a significant amount of revisions happening on the shunts that we don't necessarily account for usually. Now, this is then the challenge now. Hydrocephalus could be treated through an endovascular approach, and how would you do that? And would that each be better or not? So there is an equipoise to that question. And this is what we're trying to reestablish. Basically, you have the drainage like through the granulations of Pacquiao, like we discussed, and can we achieve the same thing that the shunt is doing? Normally, we're trying to drain through the lateral ventricle all the way down to the peritoneal cavity. But can you potentially reestablish the circulation by keeping everything very local? And we started, very recently becoming extremely familiar with the venous anatomy and the implications that have on the absorption of the spinal fluid. And one of the conditions that we're treating more and more is now the second condition that I'm talking to. The first one was a CSF venous fistula. Now we're going to talk about a condition called idiopathic intracranial hypertension that in the past, also we would usually do optic fenestrations or place a shunt, use Diamox to decrease the production of CSF. But there is evidence that perhaps in some cases there will be a benefit that if you identify a venous sinus stenosis by placing a stent on usually the most common location is transverse sigmoid sinus, that you can reestablish and remove the gradient or the pressure gradient that exists because of the stenosis, and that can improve the drainage of the spinal fluid and alleviate the symptoms of idiopathic intracranial hypertension. Incredible, right? Like this is really something that shows that we are from the arterial side, now we're moving more to venous side endovascular procedures. But it turns out that the neighborhood, if you look around the veins in the brain, there are certain areas that you have a large venous pathway, such as the inferior petrosal sinus. And this is laying into a cistern very close to an area that you have enough real estate that you could potentially place a drain from the inferior petrosal sinus to the cerebellopontine angle cistern. And this is really anatomically a very nice spot to be able to consider for an endovascular approach for hydrocephalus. So once that anatomy was recognized, a lot of things were done, and a lot of it was to show the concept that if you are able to bridge, to poke a hole in the inferior petrosal sinus and slide a tube, a catheter or a little tube that goes from the basically the CSF space, the cerebellopontine angle cistern, and anchors that you have to have a little anchor on that place, and then it drains into the inferior petrosal sinus, the CSF. You could bypass the flow or improve the flow of the CSF. So that was kind of the working position, the anatomical spot that was identified. This is how the procedure looks like. Basically, you can see here that you have an anchor that keeps the tube in contact. This is going through the inferior petrosal sinus wall, through the dura, into the subarachnoid space. Okay, and the shunt is long enough that can stay in the inferior petrosal sinus or come all the way down to the jugular vein. This is the size to give you an idea of compared to this is American money, so you may not be, but it's pretty small. You can see the hands here. It's a really small tube, and this is it has a slit valve, so that's how it controls the drainage. And there are some videos that you can see here how the contrast is coming out of the slits there, and this can be seen potentially on a gadolinium injection on the subarachnoid space. So you can potentially see that drainage there to check patency of the shunt. It is really exciting. Okay, so this is probably the most important slide, which is this issue of a lot of my colleagues have asked me, like, is this going to overdrain? How do you control how much it's draining? So it turns out that the flow, it will depend a little bit. You have to have when you do the lumbar puncture to see, we call it tug test, which is to evaluate if the patient gets better. The NPH patient, once you remove a large volume of spinal fluid, you will see if they perform a walk before and after this large volume tap to see if they do better or not. And the pressure that we measure has to be more than 8 millimeters of mercury. So you have to have at least that to be able to have the shunt function. So if you have too much of a low pressure, the shunt would not work. Okay. And this is the column difference. You can appreciate that the distance we are talking about is about 3.5 centimeters is the distance between the inferior petrosal sinus or CSF cistern to the jugular. And here is way if you go towards the atrium or peritoneal shunts, or even pleural shunts, you have 33 centimeters, and in the long pleural peritoneal shunt is 68 centimeters in average. So this is the kind of you can see here the variation of what you see with the ventricular peritoneal shunt being 50 millimeters of mercury. The ventricular atrial shunt is 24, and then on the E shunt is about 2.6 millimeters of mercury. For safety, in the study, we have to do only in patients that have 8 or more millimeters of mercury pressure. So this is also, this is really, and I will show you a little bit our case in a little bit that we've done. But the planning for the procedure is key part of this. So the first thing to do is the patient will be evaluated clinically to signs of normal pressure hydrocephalus. If they fit the bill and they want to be part of the trial, they will be then sign a consent, and they will randomize to either regular shunt versus the E shunt. And so we are doing basically a randomization 1-to-1 ventricular peritoneal shunt and E shunt. And so the patients then go through a new spinal tap with large volume, usually between 30 to 50 cc's of spinal fluid is removed. And then we see how the patient does on the tug test walking. We also do a MoCA test for cognitive assessment, and you do an anatomical assessment of the angle of the inferior petrosal sinus, as well as the thickness of the size of the cistern. So all that has to be done. If this becomes all okay, then the patient goes to randomization. This is a little bit of how obviously the procedure is done as an animation. You can see we place here, we do actually amazing contrast injections in retrograde to actually see, but there's an anchor. This anchor is about, let me go back here. So you can see here that you have this, it's like a stent on a stick, like a stent retriever, and that actually is anchoring. Usually we put this all the way down to the sinus, usually the cavernous sinus area. Okay, so that it opens there. We have to be extremely careful. Most of the possible transient complications that we're seeing were 6 nerve palsies, and that was transient, but it was likely because when you open this device in the cavernous sinus, you could have compression of the nerves that are passing to the orbit and that area. So that's one of the things that we need to be careful. The new generation of the device is coming without this, so we're not going to need to go all the way to the cavernous sinus. But you can see that now that this anchor allows, because of the angle of the inferior petrosal sinus, when you advance the device, you see that there is a little sheath. You pull the sheath back as you're going the curve so that the needle is stiff. So this will not make the curve, it will go straight. And that's when you puncture the inferior petrosal sinus and the dura. And this is an incredible moment. The first time you do this, it's a very exciting thing because it is a sense of freedom. You're going out of the vascular space into a different space. You're going transvascular for the first time, really, on purpose, and really amazing. And this is not easy. Sometimes you can have bone overhanging there, so you need to find. That's why the preoperative study tells you exactly where to go. That you have no bone and the dura and the sinus are possible to perforate. Then once you have access to that, you slide the shunt and you deploy. This opens automatically, and then you pull back the system and the shunt stays in position. It looks very simple. It is very simple. Actually, the procedure I did in about 20 minutes. The issue is more the training, what goes before, how we'll select the right cases to do this. And right now, to give you an idea, this is we screen maybe about 20 patients to get one that can be a good candidate. So it's not like everyone can get this right away, like it's a very selected population. So the 3D reconstruction is essential. So just to show you, the CT and MRI are very important to be able to locate the anatomy, to understand what is going to be done. You can see here that you have different ways to do this. You can pick on the CT and then overlay on the angio the spot where you want the needle to go through. So when you're doing the procedure, you can have that little marker there from the CT anatomy of where's the best place to do it. So you can see here now the needle approximating. You unsheath, and then it's going to be right at the spot where we saw that there's no bone, nothing there. So you go and push the needle through it. You can see that, and then slide the catheter over that. And then you will see that you pull back. When you pull back, the anchor stays in position, and then you resheath. And you see how this was in the cavernous sinus there. And this is how it looks like afterwards. You can see the position of the anchor there. I think let's just take a look on what has been published. A lot has been with our friend Pedro Lilik in Argentina, and he's done really the first in human. And after that, it was actually initially a subarachnoid hemorrhage case. And then the first pilot of the normal pressure hydrocephalus cases. And then we have a pilot in the United States also that was done for NPH. And then we are now on the study called STRIDE, which is a larger study that is doing in the United States with NPH. So that's the one I'm part of now. I think there are plans to do also subarachnoid hemorrhage in the future more, but right now the focus has been mainly on the NPH indication. So NPH, we talked a little bit about that, and I talked a bit about how we screen these patients. I think the gait is the most incredible thing that patients that had a significant gait impairment are probably the best candidates to get function back. The cognitive decline and urinary incontinence issues are a bit harder to improve, or takes longer to get better. But I'll show you a little bit of where we are today in terms of the timeline of what has been seen on the first 90 days post-procedure. So this is a kind of a long process. So we have actually a specific clinic for normal pressure hydrocephalus. So if you have a patient and you want to refer to that, exactly, they will come in and they will see all the specialists with one appointment, because we know the mobility is an issue for these patients. We want to make sure that they all come to see us in one clinic, one appointment, and get all the scheduling of the next things to do. And these are the issues here. Normally, you have to do an informed consent, you do the LP test, you do the cognitive test, and then you assess the CT and MRI imaging. All that takes a few steps to get done and has to be very well organized. So I have to say being part of this study allowed us to organize our NPH workflow in an incredible way. And I think we're doing really an impressive job on getting a lot of patients through and screening them for the study. Obviously, once the patient gets the procedure, we have assessments at 90 days and 1 year after that. And so far, this is one patient, you see the clinic pre-treatment, this is a TUG test. So this is, you'll see the challenges, the kind of the shuffling gait and very hesitant. And you can see how difficult that is there. Oh, Reynald, do you have a question or no? You're okay? Okay. And here's the post-treatment. So you can see a much better way to do that. And,
Yes, Professor, when you finish.
okay, thank you.
Sorry.
No problem. So here is you can actually see very interesting the gadolinium draining into the jugular vein. So you can test the patency of the drain. So you can see on the MRI, so it's MRI compatible. And if you do a 3D cysternography with gadolinium, you can see the patency draining into the jugular vein. So here are the pilot study, which is really a smaller study. It's 59 patients were treated, and then you have an incredible, 1 year of the 18 patients that were assessed. There was definitely an improvement in 94% of those patients that were seen already at 1 year. And I just saw at ESMINT, I think Ivan Lilek presented now about 4 years of follow-up and looking really impressive, the results. So I'm happy to see this. I think this is really compared to shunting that you had a comparison improvement of 76%. I think this is looking favorable that it could be a good therapy for patients with normal pressure hydrocephalus. Obviously, we're going now through a true randomized study, and we'll see that in the end of the study. Here is what we talked about, that the improvement in walking, which is a TUG test, compared to cognitive in the bladder. You see the difference. The walking improves in a significant number of times. It's a very powerful improvement. The cognitive and urinary come a little bit behind, but it's still, anything you improve. Remember, this population, many of these patients are going to like nursing homes, or the family cannot take care of them anymore. So it's really helpful if we can get some function back so they can do things again and become independent and safe. And here is the same showed a little bit in a graphic way. So just showing that at this point, the TUG test improvement is really beyond what we expect. Is really, really impressive. And the same, you can see a little bit less with the cognitive and the urinary function. So the adverse events, I mentioned a little bit of this. This is important because the complications that we're seeing were related to, in this case, pseudoaneurysm. You could, in theory, don't even do an angiogram on the arterial side. You could stay only in the venous side and do all retrograde contrast injections. So that's possible. And the patients with a hypercoagulable state, you could have, this issue. They stop anticoagulation and they have a problem with thrombosis of the sinus. In this case, was asymptomatic. I think the biggest issue that we've seen was the sixth nerve palsy, and that was transient. They all resolved in 180 days. But after studying how the procedure is done, it seemed to be linked to the placement of the anchor in the cavernous sinus. So I think by removing that now, it will be much better on the symptoms of cranial nerve palsy, sixth nerve palsy, as well as double vision. And The adverse effects, I think on VP shunt, we've seen, over drainage, infection, hemorrhage. This was not seen on E shunt. So E shunt's been very favored in terms of the VP shunt comparison, and also on the serious adverse events. I mean, I think that the E shunt has been very favorably compared to VP shunt on that, at least to the literature comparison, and we'll see on the trial now. All right, so this is just how this image looks like in 1 year. It seems to be not moving and staying anchored in position. I think the safety profile made it then go into the STRIDE trial. This is the name of the trial, STRIDE trial, and that is now actively recruiting. We have recruited 2 patients at this point, and we're very excited about it. So this is how the trial looks like. We randomize after passing through all those things we discussed, and then you go to shunt versus e-shunt, and then you follow them up to 1 year after the treatment. And efficacy will be gait improvement, and safety, of course, is number one, is infection, over drainage, intracranial hemorrhage. That's what we're looking for to compare. Okay, so I'm getting to the end. It's about 30 minutes of this presentation here. Let me show you a few things. I just want to show you that it is incredible that we are going transdural. And Luis, I know you love this because I think that the amazing perspective of delivering therapies in the spinal fluid, like medications through the endovascular route, or potentially draining hematomas, or potentially doing a shunt procedure. Those are things that were unthinkable before. So I think this is really a very important phase of endovascular therapy. And I would say I would compare to a little bit of what cardiology went from coronary intervention to then structural disease. When they start fixing valves and holes in the heart wall and stuff like that, it's the same potentially phase that neuro is going through.
Excuse me, Demetrius.
Yes.
Yeah, we have lots of time. Don't worry about the time.
Okay. No. And no, so I'm thinking like this.
No, don't worry. Demetrius, you have every time for you. Don't worry. Please.
No, but I do think that the main issue here is that you have this you're going through a phase of structural replacement, or that in the coronary, in the cardiology space, interventional cardiology, they went through that probably in the beginning of 2000s, and we're seeing this now at this time for us, that we are going beyond just fixing aneurysms, acute stroke. Now you're going to new diseases, new problems, and this is really, I think, the power of this investigation. I feel that also the Ceravasc team, and they're very much, I think, Adel Malik, they've done an amazing job in validating the technique, and I think I have to give them to be part of the trial has been incredible. I want to show you a few things of what I received as an investigator to get ready for the procedure, but this issue of the not only solution for NPH, but other conditions, and the deliver of chemotherapy or types of gene therapy through the CSF are on the horizon for this. So it is a platform for the next generation cisternal neurosurgery. So we're talking about even potentially navigating endoscopes through the spinal fluid, or doing all kinds of things that would be incredible to do. This is from Matt Gunis, and he's showing us the cisterns evaluation, a sheep model, and you can see that the ability to reach the limbic area, the temporal, see the ability to deliver medications to different locations depending where you're delivering the medication. So having access to CSF, it may be important not only to drain the fluid, but also to deliver medications there, or gene therapy, which is really an exciting new chapter. And this research is ongoing already and very, very much on the way. I think that for us, obviously we were very excited about doing this, and but it's really looking into bypassing the blood-brain barrier and be able to get into the CSF. I think that's a real improvement of our capabilities. This is something that in the past, with endovascular techniques, you would not be involved on these discussions, but now we are. And let me show you this. This is a OCT. We're just starting the neuro OCT trial in the United States, and this is a neuro probe. This is intravascular imaging. But you see how cool this is because you have basically, let me go back here, sorry. You have here an aneurysm that normally you would not treat. Looks small, looks very benign looking, but when we did the OCT, and this was done in Buenos Aires, you can see here that we can see the subarachnoid space. And you can see beyond the vessel. So you're looking at 12 millimeters from the probe. The probe is here. See, the probe is here. So you can see the depth of subarachnoid space and the structures around that area. Obviously, in this case, what was amazing was that you could see at the aneurysm level, you could see that the thickness of the wall of that aneurysm, it was so thin that we recommend this was like less than 30 microns of, and here you can see in this side right here, you can see a perforator coming out right there. See that? So perforator coming through the vessel wall, and it's just ability to see the subarachnoid space, and here you can see the thickness of the wall of the aneurysm. In this case, like a 0.04 millimeters. It's very thin. What this is here, and so a flow diverter in this case was placed, but you could see potentially blood. So if you have multiple aneurysms, you can see blood close to the aneurysm in the subarachnoid space, which is really helpful sometimes to identify which aneurysm rupture. And also you could have see how thin that is right there. And incredible, no? And this looks so normal on the angiogram, like not a big deal. And then this is turned out to be incredible. Now, the other thing you may have heard is here you can see the intima, the media, and the adventitia. So incredible anatomy. But there is something that's been discussed a lot. It's called the glymphatics, which is the ability to the lymphatic drainage of the brain, and that the relationship with Alzheimer's potentially. So the amazing thing is that by seeing the subarachnoid space or getting access to subarachnoid space will open to us a much bigger territory than maybe the vascular territory was. And I think we started with arterial, then we went to venous, and now we are in CSF. And I think this is really an incredible journey for us to explore that. These are some publications that we have that I think it would be exciting to catch up and see what was done in terms of OCT. And let me see if I have this here for you. Well, I think, I will stop here. I just want to see if there are any questions or anything that I could answer. I know I've been talking for the last 40 minutes. So again, Luis, Reynaldo, John, thank you. I think Fitri, I hope you're there too. But it's really an honor to see you guys again. And Luis, it's been a long time, and I feel that we missed Madrid, we missed the meeting. I think it was really a great thing to do before going to Val d'Isere. We really would love to restart that or do this in any format, but it's really great to be able to catch up with you. And by the way, I have talked to your son recently quite a bit regarding his journey in medicine, and I think it's amazing to see that how our field go from generation to generation too. So anyway, open to questions. I hope this was helpful to you.
Okay.
Thank you, Professor. Right now, the Professor Luis Lopez Ibor, he doesn't need a presentation. He's a genius. Your presentation, Professor Demetrius, is very, very impressive for me. Right when the professor finished, we were talking about this topic. Thank you.
Okay, thank you. Thank you very much, Demetrius, and everybody. I think Demetrius and myself have a telepathia. I don't like the psychoanalyst. I know very well what is the telepathia. I have two presentations. It's only 3 cases, but Demetrius live in Chicago and have the powerful from United States of America. But the mind of Demetrius is Hispano-American. It's the same of Colombia, Peru, wherever you want. The hypernormal pressure of the hydrocephalus hypernormal is described with Hakim and Adams. Hakim is from Colombia. You know that, the idea, both. Okay. I like to present you. Pónmelo todas porque voy a arrancar de la. No, más abajo, más abajo. No, es que yo lo pongo. I'd like to present you Demetrius, everybody. I treated one patient about 15 years ago. This patient is treated by have this long history of the dural fistula, carotidocavernous fistula, acute fistula, no traumatic, and possible to treat. Many looked at is your thrombus of the patrocynus, non-word the lateral sinus, only the cortical venous anastomosis with the Rosenthal vein and striate sinus. And this is the pouch of the cavernous sinus. AP view, you are the feeders. I don't like to talk the anatomy with the juniors, they know very well. And you are here the pouch, you are the vein and the venous drainage. The first step to treat it, this is in Spanish, is to treat, just a minute, to put a balloon here. It's impossible to canalize well the cavernous sinus. I decide at this time direct punction with the trigeminal axis. AP view, lateral view, rupture the wall of the suprainguinal space. Look that, foramen oval. Balloon protect the carotid system. Punction. 3D is in 2010, 2010, 50 years ago. Look that. Foramen. It's nice, Demetrius. Look that. And then I push the catheter and deep wire. Some movement, only this. It's impossible to cross with the coil. Only this. Mm-hmm. Probably I have a intra-intimal hemorrhagic, suprarenal hemorrhagic. This is the control. Totally occluded the dural fistula. Direct punction of trigeminal axis. It's the same as you present now.
That's beautiful.
The second, I like Demetrius because really you are in the same way of my mind. Pónmelo ya grande. This is for you, Demetrius. Embolization of high flow fistula and AVM, PL or AVM. Alert sign, alarm, ventricular size. When I learned in Paris, I learned with Professor Pertuset, describe the progressive exeresis of the brain AVM because it's the only work to combat the breakthrough. This is the same with us, I embolize step by step. This is the thesis from Pertuset, reduction chirurgical, blah, blah, blah. But it's very interesting because to learn or study this system of this idea, don't have only have the CT scanner and gamma graphic study, nuclear medicine. I compare the patient with nuclear medicine and CT scanner and hypotension. Also, of course, I learned with Pierre Lajunias, 6 years, and vein of Galen fistula in 1983 to 1986, I treated with Pierre 12 vein of Galen. And I describe my surprise. In the vein of Galen, si you close the vein, the hydrocephalia is okay, it's here, no? But if you close the feeder, you decrease the hydrocephalia. You don't attempt or inflate the vein. Only with that, you decrease the hydrocephalia. Why? Stop the flow. This is the talk before Demetrius, the subarachnoidal space, barrier hematoencephalic, vascular flow, arteriovenous, is connected. It's not, and this is interesting.
No, that is really interesting. And if you show the ventricular size before and after, is incredible how it resolves the problem. It's amazing. Yeah.
Yeah, thank you. This is patient treated by myself in Medellin, Colombia, for 3 years, half the patient. I treated with glue. This is the facial posterior sinus. This is trisinus. This is the hydrocephalia. The same. Partial thrombosis, not totally, occluded the fistula and decrease the pressure. This is another patient from Lamu in Yemen North. This is the mother. This is the Spanish nurse. He come to Madrid, and this is, look at Reinaldo Demetrius. What is that? You are a high flow fistula, bigger pouch, facial sinus, stenosis in the straight sinus. This image is in Congo. This is MR in Spain. You are here some hypersignal around this pouch. This is the MR angio, more compressive, the anatomy. What is the connection? Okay. This is the hydrocephalia. And this is the angio. Vertebral, left, right, and left. You are here. This is the junction of the basilar, and this descend to the pike, the right. This is the pike,
Awesome.
okay? Why to treat this? Lateral view, and carotid injection, you are the inversion flow, just in point of the direct fistula. I decided to treat this with both injection in the carotid system and vertebral system, and you are the anatomy. This is a junction point. This is a junction point. This is the point of fistula, high flow fistula. I decided to push a balloon here in basilar artery and put coils here to protect no migration of the coils. The lateral view is more comprehensive now, Yet. You are here, the balloon in the vertebrovascular system, you are the coiling, and you are the result. Totally close. Fantastic result, imaging result, but 6 hours later, the patient developed intracranial hypertension because you stop the shunt, the high flow shunt, in one step. Stay about 3 weeks in unit care to decrease the pressure with many medical management. This is the control. Finally, the patient looked at going to the Bernabeu, to Real Madrid with the mother, and then few years later, totally cured. This is a fantastic result. For me, the important is learn. Stop the fistula, in high flow fistula in the brain or EVM, be careful. Another case, is the last case, is the EVM with high flow fistula in the nidus. I treated this fistula with glue, with pure glue. Look that you are the glue in the pouch. Some vessel we protect with coiling or onyx, but this is the glue. After embolization, the patient developed deficit with change of the around of the fistula AVM. This is the control. This is the reason, finally. I like separate embolization session timing. This is, for me, is important because it's very difficult to know before we treated the patient where is the result you are with the patient. It's craziness. This is true. When I live in learning Paris with las Juniors and Pertuiset in 83, I know this problem. Now everybody don't know this problem. You are new products, new device, whatever you want. And also my father is a psychiatric and neurologist. I know very well the Huntington and dementia with hydrocephalus pressure, blood pressure normal, and I know with this philosophy. It's only, I think it's only Demetrius, it's incredible. I prepared this talk. I don't know where you talk. I have the same idea. Congratulations for your progress in the health. Thank you.
Luis, these are unbelievable cases, and No, I think you summarized extremely well for everybody that attended today and will watch this in the future. I think this is like you call a master class on the connection between the venous or vascular system to the CSF space and how much these things are connected and how much we don't know about it. And I think I alluded a few things on this issue of a cognitive decline. I think as we get older, obviously we think more about that, but I think it's incredible if we can improve our longevity, cognitive longevity because of CSF malfunction that we don't even know right now. But really beautiful and looking forward to see you soon. I hope your family is going well, and thank you everyone for this opportunity. And I'll see you.
A question.
No,
Yeah.
just a minute, Reynaldo. I
Yeah.
like to talk with Demetrius. It's an opportunity to Demetrius. You go out?
Yeah. Uh-huh.
Oh, no, it's okay. Okay, listen me now. I treated my Reynaldo. ¿Cómo se dice mi suegra?
Oh,
Nephew.
mother-in-law.
Mother-in-law with chronic tuberculosis meningitis.
I remember
I
that
remember.
case. Yeah.
I have only two patients. One is my mother, and the second is a missionary from Africa. But this is not the question. The question is the tuberculosis arachnoiditis chronic meningitis. Meningeal tuberculosis chronic. The meningeal don't move. And don't move, the brain don't work. And you are the hydrocephalia, and you are the hyperpressure. I embolized with glue, both middle meningeal artery and PVA with 100 micron.
Wow.
Yes, bilateral. Finish this. My mother come back well to Colombia 10 years.
Wow.
I have two cases. I don't like to publish that because it's really crazy. Mrs. It's the same you talk. The movement, the subarachnoidal and líquido cefalorraquídeo is the same. Is the heart of the brain.
Yeah. Yeah.
It's important. You talk.
No, I think now too, Reynaldo, go ahead. I'll let you ask your question. Go ahead.
Oh, thank you, Fernando. I have a physiological question. When do you realize this shunt, you have a switch intracranial pressure reduction for 38 less 20 water millimeter pressure? It cause any in the liquid tension in the brain, any problem? Is demonstrate any problem or clinical? I don't know. Sorry for the question.
No. I think the main was that the first patients you saw was subarachnoid hemorrhage patients. So they had EVD in place and they had E-shut. So you could measure the pressure in the ventricle at the same time. So you could see what was happening. And it was a very gentle change on the pressure. So it was not an over drainage or anything like that. And obviously on the NPH population was a really incredible result to have not to have the patient have to recover from, the hospital. The patient stays overnight in the hospital, goes home the next day, doesn't have to have any wound to heal from. And the ability to, it's an early experience for me, but so far we have no complications, no sixth nerve palsies, no double vision, no over drainage. So the ventricle seems to be like gently drained. And remember, NPH is tricky. It's not about draining. It's not a hydrocephalus obstructive hydrocephalus.
Very
It's
micro.
very minimal. Exactly. It's a minimal drain. And so I think it's perfect for this population. But I feel that the if you pass the tug test, you are going to respond to it. And I feel that it's early in the stage, but I feel that let's say if it's equal to shunt, both are successful. It may be that you are opening the gate to more the transvascular approach. That's kind of the idea here, is that if you choose to do in the future, it's going to be an option like a E-shunt or VP shunt. Both are options, but and maybe that I told you is not everyone that is a candidate, because the cistern has to be a certain size. So it's not 100%, but it's the beginning of a new phase, right? So
Demetrius, one final comment, because I think, I'm sorry, John, because it's important.
No, we have lots of time. Don't worry.
This 5 minutes. Demetrius and everybody, the theory of Zamboni, Paolo Zamboni, to treat it, angioplasty of the venous system of the multiple sclerosis, because attempt with the venous space, virtual space, to draining the histochemica of the brain in the multiple sclerosis. And the second point is the theory of Abulker, is from Oran in Algeria, live in Paris, and describe the paraplegia, chronic paraplegic, with the patient have a stenosis of renal, medular, anastomosis. If you want another time, I present with you, because it's important, because I know now with I learn in Paris, or I learn in NeuroMSA, I learn now. I like it. Thank you. Thank you very much, Demetrius, for your conference.
It's a pleasure. Fitri, you have a question?
Fitri?
Fitri, you muted.
Yes,
Good,
thank you, Professor, for it's a good presentation, good lecture, and maybe I'm who the ones here who not a neurosurgeon or neuroradiologist. I'm only a anesthesiologist. My question first is like first, how the position of the patient, because it's a PA here. Usually it's if the open surgery it will be like a semi-sitting because you have like a sitting position or back bend usually our college how you do it in the when you put your wire. A second time when I saw your video is first is like a wire is like a near official, a surface of official, because it's a one time also you have a cases that we must help a neurosurgeon that the wire is stuck to the vessel. It's stuck. So how you
remove that? Yeah.
yeah, you remove it because you guys like after endovascular is like a bring to the OT is twice I saw it that he opened. That's why you always said that
No, I mean, honestly,
maybe
right, we really enjoy so much Yuha. He's was a really great friend.
it's a great
I,
great neurosurgeon.
I'm glad you're here, and I think certainly that's the thing. Madrid was one of those moments that everybody came together like that, and I'm sure that today he would be very proud of this discussion, because I think. As a neurosurgeon, just like you, we have the ability to access this part of the brain. We do this, and is basically you're laying flat on the angio table. So you use actually X-ray guidance to navigate through the vein. So you get actually access on the femoral vein on the leg, and you travel all the way up through there's a connection right at the skull base. The jugular vein allows you to go into the inferior petrosal sinus. You can actually go directly into that location. And what I was very impressed by this procedure is that when you inject contrast retrograde and a large syringe, a 20 cc syringe with contrast, you can actually go against and create a map of the whole inferior petrosal sinus, cavernous sinus, everything. And normally I did that through the arterial side, and I would inject and do a delayed imaging, a roadmap. But now you don't need to. You actually can go with our catheters and inject retrograde, and you get the map. Now, so all these procedures done transvenous, going through the femoral vein, and the patient is laying flat in bed. Now, you bring a good point. If the anchor stent gets stuck there, you cannot remove it. That's possible, I guess. But the one of the things we have today is that we do have more options than I remember when I think Juha was practicing. He had the endovascular colleagues had less options of catheters and different techniques. Obviously, this has evolved so much now that we have way to go back up and resheath with a new catheter going up. Obviously, if all fails, I would say we tend sometimes to leave behind and use antiplatelets and let it heal in position. If it's that stuck, I don't know if I would go with open surgery to remove it. I may actually let it heal in position. That's one way to approach that too, you know. But I think that you know, if it is in a vital location that we cannot leave it behind, then open surgery obviously is always an option too. But you'd have to do in a different angle position of the head because it is not easy. Yeah, yeah, it's not an easy location to get to. So good point there. Thank you.
Yeah,
Fitri,
maybe one question.
no, no, just a minute, just a minute. I repose your question. Why the position of the neurosurgery is different to the endovascular approach? Why? Because you don't open the dura.
Oh,
You are this is the only thing. You open the dura, you change the pressure inside the intracranial. Only this.
yeah.
Okay,
One question again, Professor Lopez.
Yes.
Can I?
Please.
Yeah, further. So in these cases, if I'm not, because my English is it's so broken
Perfect.
English. You always say it's a broken English.
The
I'm
same
not.
level, the same level.
No. My English is not good. So if I'm not wrong, it's like a hydrocephalus. So if in your opinion is needed to be a lumbar puncture or something with a ICP monitor so we can reduce the pressure of the
Yes,
head.
I understand. I understand. Demetrius is neurosurgeon. I know better for me this question because before to treat it with the external valve, before you check the punction lumbar and you check where is the pressure low and you check where is the valve and you are also the possibility to treat the lumboperitoneal system. Okay, this is incredible. One final comment, Demetrius. I have some case when I inject the spinal artery in the cervical region and rupture the vessel and have the myelogram. This is incredible because it's a real connection. I treated also the patient with the venous approach and the cervical approach to treat the nidus AVM. It's impossible to close, but you push forward and you attempt the golden nidus. To resume, if you are one petrous sinus closet, it's possible to open.
That's
It's
right.
possible.
Yeah, and that is definitely one of the things we do for access to fistulas. Like in the case you show, you went percutaneous, but sometimes if you cannot do that, you may have to go to reopen a sinus, and for sure. But you know, I think a very exciting topic, you know, and we have so much that we can go. Another area that is very interesting now is the treatment of migraines with MMA embolization with lidocaine. And this is really exciting. New field, we're seeing a lot of trials coming out of this. So I think that these are all new horizons. I think applies to your course and here. So these are different topics that than the routine we used to do of aneurysms and stroke and all that stuff. But now
Yeah,
there's
of
so
course.
much more, you know. But well, anyway, guys, I appreciate everyone. Thank you so much, and have a
Thank
great.
you.
Take
Next
care.
time in Madrid in January. Okay, I
Let's
organize
do
the
it.
neuro.
Yeah, that was a great webcast to watch, Demetrius, and I really appreciate you putting the time in. And I extend the opportunity for you, if you want to do a presentation on migraines and lidocaine in that area you talked about, just let me know.
Okay.
We could do a webcast. And Louis, so I think it's on the writings on the wall. You gotta have that webinar in January or February. And we'll all be there. We'll
I
all do the
continue-
flamingo and we'll go to the Prado.
I continue the learn for my friend Juha, Professor
Yes, in honor of you, huh?
Yes.
Okay.
Okay. Thank you very much,
Bye-bye.
everybody.
Thank you. Thank you.
Muchas
Thank
gracias.
you.
Muito
Thank you,
obrigado.
Professor Demetrius. Thank you. Thank you. Gracias, Professor Luis.